We have Dr. Giriraj, please, to talk about scleral tuck IOL now.
So one quick comment about the iris fixated technique is that it's a very good and a fast and easily it does not have a much learning curve. But the point here to remember is if it is done in a limited vitrectomized eye, it serves your purpose well. Suppose I'm doing a total vitrectomy, especially in cases of Marfan syndrome in subluxated lenses. Anyways, the scleral rigidity is very less, and you implant iris fixated lens. There's a lot of oscillopsia. The iris lens diaphragm oscillates, and the patient will complain of oscillopsia. So it works very well in limited anterior vitrectomy versus it does not work well in a totally vitrectomized eye.
And which is the choice of lens, iris claw lens, which you used? Which brand of lens? Okay, that's one of the most popular ones, I guess. Thanks.
Yeah, thank you. The other day we had huge fun debating about the iris claw versus SFIL. I think it is continuing now. As someone asked just now, yeah, for the vitreoretinal surgeons, why do we choose scleral fixated IOLs? Most common reason, as discussed by sir, oscillopsia and ovalization of the pupil. And some people do develop chronic iritis. But ultimately the answer to the question is whatever works best in your hands. That is the answer to all such questions. Now just the comment which was made that scleral fixated IOLs take more time. So now I'm coming with that. Yeah. Yes. So yeah, conventional sutured 4-point fixation have been discussed earlier. Flanging technique and Canna-Brava technique are some of the options available. What is the university and diversity in all these kinds of SFILs? That they need tunnel. They need a sclerocorneal tunnel. Those are non-foldable lenses. So those are some not so uncommon scenarios. This patient has a large bleb, you can't do a tunnel. What will you do? The patient might be having ciliary staphyloma or thin sclera, again you can't make a tunnel. Then he might be having a sclerocorneal tear or a peripheral corneal scarring, or poor initial wound management, or the fellow or the PG who is doing surgery must have done multiple suturing and scarred that area. Yamanis and flanging techniques or the glued IOLs, there are various problems like bulb related complications as we discussed. There is no way to standardize the bulbs, difficult titration, and to the extent of cauterization. Some people have tried even marking beforehand on the 3-piece lens how much to cauterize. Long term outcomes of Yamane are being questioned now. And as sir again said, the trailing haptic, exteriorizing the trailing haptic in cases of glued IOLs, or let it be Yamane's IOL or a Chariot's IOL, is a difficult thing and has a bigger learning curve. Chariot's tunnel, making it at the correct point and correct depth, is again a learning curve issue. So what do we have in our armamentarium in that scenario? So comes into the picture the scleral tuck IOL. This is the CMT flex model I will be discussing, courtesy to Dr. Nivian for the design. Sutureless, it is a scleral fixated hydrophilic and foldable lens. It can be placed horizontally and vertically. It provides us with the sutureless sclera. It has a large optic diameter and can be used in various size and shape of the pupil. We have done around 30 cases, and this is the study we are coming up with the centration and tilt based on the Antirion machine. Yeah, we'll be publishing that soon. Some of the technical details: it is a hydrophilic lens, optic size is 6 millimeters, A constant will be 118.0. So this is just
This is a short animation of how a T-Flex IOL is loaded into a cartridge, and as you can see that it is loaded in such a way that the T haptics are the first to emerge out from the preloaded syringe.
So that it will not cause
the leading haptic of the T-Flex IOL is gently grasped by the Pranav forceps and is brought out of the same sclerostomy site.
So with the help of it, you bring it out and it sits in nicely. So let's go with our experience. You can see this is the CMT flex lens. It has the angulation which is facing upwards towards you. You load it inside the cartridge. A 2.8 millimeter incision is made. Scleral flaps are made, and 1.5 millimeters through that we make a 23 gauge entry. Some people are doing 25 gauge entries also, and they say those are also working. We do 23 gauge and it has worked well. So the forceps number 1 goes in, ready to hold the first T as soon as it comes out of the cartridge. We hold it at the junction, then inject rest of the IOL into the AC, and slowly we bring it out. This step is very crucial according to me after doing 30 cases, so that if you pull it hard, you are going to break that. So that point we have to take care not to pull it hard, especially when you are doing the second haptic. This is the forceps number 2, which is used to hold this lens and bring it into the center. Now again, with the help of forceps number 1, you are going in through the sclerotomy, holding it, and then you bring it out. It comes out, unfolds, and sits in nicely. Another technique which we thought would be more convenient or more easier is, rather than going superiorly with your entry, this time I went temporally, so that as soon as I inject, I am ready with the other forceps to hold it. So as 90-degree being opposite, it is easier to hold and you just bring it out. Earlier we used to put glue under these scleral flaps or suture the scleral flaps, but in last 20 cases we have just made the scleral flaps a little bigger and made sure that they are closing this T section, and over that we are just closing the conjunctiva and did not have any incidence of hypotony or anything. Yeah, but I just want to share some of the complications which I faced along with it too, because the coin will have two sides, of course. In this case, everything went on well. I injected, I brought it out nicely. But yeah, other side is also tucked well, but as soon as I was removing the trocar, I saw the other end going down. So probably I had pulled the other end a little more, what do you say, with a little extra force. So now you can see the T is broken. So I have to bring it out. Again, because it is a hydrophilic lens and foldable lens, it's not so difficult. We don't have to extort to a tunnel and everything. You can just rotate it, cut the lens and bring it out through the same opening which we have made, and place in a new lens in that through the same section. This time although being more careful. So in this second case, what has happened is, you can see the T is intact. This was 2 weeks post-op. I had done this in an 8-year-old kid. So the T is intact, but again the lens has gone in. We thought that the T, it has folded on itself and it has gone in again. So this guy had a scarred sclera, as you can see on the other side also. I initially thought I will explant it, but then I just brought it out. Then at the neck, I took a 90 proline suture tie and anchored it. So I just wanted to share these two complications which I have had and how we managed with that. Afterwards, I made another scleral flap to cover this. So take home points: CMT Flex provides us with an easy and fast technique if done properly. Foldable, no tunnel related complications, no suture related problems. Long lasting results, although awaited, it doesn't have the inherent suture related complications of degrading and all. And it has a small learning curves. Our fellows are also doing it quite easily now. So yeah, that's all. Thank you.